Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori, sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an intensive care nurse, and I'm proud to work with a multidisciplinary team to work together to fight COVID-19. Together we are intensive care medicine.
I'm an anaesthetist, and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together we are intensive care medicine.
I'm a primary intensivist, and I'm proud of it. We intensivists are working together side by side to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist, and I'm proud to be an intensivist. We intensivists working together to fight the COVID-19. Together, we are intensive care medicine.
I am a surgeon, and I'm proud to be an intensivist as well. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello everyone, I am Maurizio Cecconi and I'm the president of the European Society of Intensive Care Medicine. I am live from Humanitas Research Hospital here in Milan. 2021 started with the hope of vaccines that are rolling out throughout the world. We are in Europe and we're seeing numbers increasing of that. But the other big news has been also the so-called UK of SARS-CoV2. I worked in the NHS for many years. I've been in contact with colleagues that have been reaching out over the last few days, telling me that what they are seeing is fast and it's a story worth telling. So I'm very pleased to host this webinar today together with the Intensive Care Society. We have a panel of experts of frontline workers, Stephen Webb, who is also the president of the Intensive Care Society. We will have Rupert Pierce from London, Charlotte Summers from Cambridge, and I will be joined also by Adrian Wong, also a frontline worker in the UK, that will be monitoring what's happening on social media. So feel free to send questions, to send comments, and we will try to ask these to the colleagues at the end. So without losing any more time, it's a real pleasure to introduce Stephen Webb, a consultant intensivist from the Royal Papworth in the UK. He's also the Deputy Chief Medical Director of the hospital. He's the President of the Intensive Care Society. And I'm very grateful, Stephen, for you guys finding the time today to tell this story, which we think is very important to tell. So thank you for this, and I leave the stage to you.
Hello to everybody in Europe who is watching this webinar. Thank you for the introduction. I'm Stephen Webb. I'm speaking to you from Royal Papworth Hospital in Cambridge. I'm a consultant here and president of the Intensive Care Society. And I think we all hoped that 2021 was going to be a new year, a new beginning, and perhaps time to get a break from what we had seen in 2020. But I have to say, sadly, that has not been the case. Here in the UK, 2021 really has started with a bang. We are extremely concerned about the situation here at the moment in the UK. We've been talking about that widely to colleagues and to media here in the UK, and we're very pleased to be able to tell the story to our European colleagues. Despite Brexit, am I allowed to mention the B word? It's good that we are as close as ever and able to communicate effectively and share our story with you. We remember very, very clearly, Maurizio, you personally telling the story to us in the UK about the situation in Northern Italy in February and March at the beginning of Wave 1, and how you really told us to get ready because this is serious. And now it's our opportunity to say to you to get ready. This is serious. So the situation in the UK, you'll hear a lot more about it from my colleagues Rupert and Charlotte, who are the experts and are certainly experiencing the situation on the front line. But in summary, we are really struggling at the moment. There are significant problems with ICU capacity in the south of England and in other parts of the country as well, spreading right across the country, Wales, the Midlands, the northern part of England as well, and Scotland and Northern Ireland. Our staff are under severe stress and strain at the moment, being stretched beyond their limits, having to look after more and more patients. We're having to create expanded critical care units as we had to do in wave one. But I think we all feel that perhaps this is even more challenging than wave one. You're familiar yourselves having dealt with those situations in wave one, but we are now experiencing themselves in wave two. So that's really what I wanted to say. I wanted to say thank you for welcoming us. Thank you for allowing us to speak to you. We, as the Intensive Care Society, are delighted to work with you in the European Society of Intensive Care Medicine so that we can tell this story, get the message out so that our European friends and colleagues can be ready so that they can treat patients better and keep patients safe. Thank you, Maurizio.
Thank you, Stephen. And you mentioned that in March we sent a message of get ready to the rest of the world. But if I understand correctly, you're now sending the message to the others. I don't know if there is one short sentence that you want to send out to colleagues and to citizens about what's happening in the UK before we move to the next speaker.
I think the main message that we want to say is that this is real, this is serious, this is potentially worse than the first wave. This virus, this new variant, B117, is more infectious, more transmissible, and it appears very worryingly to be affecting younger patients as well. We do not yet understand all the details behind it. We don't understand all the science, but please, Europe, be ready and be prepared.
Thank you, Stephen. We will come back to more questions to you at the end in the panel. It's time now to move to the next speaker, Rupert Pierce. Rupert is a friend who is also a professor of intensive care medicine, a consultant in intensive care medicine at the Royal London Hospital in London. Many of you may have been following him on Twitter. We've seen his updates from the second wave in September, but more worryingly recently, with this third wave with the new variant. Hi, Rupert, how are you?
Hi, Maurizio. Busy, but okay and safe, thank you.
Thank you for finding the time to speak to us. The stage is yours. Please tell us what you think it's important for us to know.
Thanks, Maurizio. Well, I mean, I'd start by echoing everything Stephen has said. The situation is genuinely serious. And as we learned to gear up for the first wave based on advice from friends in the north of Italy in particular in the spring, we want to warn colleagues across Europe that the same call to arms is needed. And I hope that any response you prepare for isn't needed, but you need to be ahead of the curve in case it is. In the UK, in the first wave, we peaked at just over 3,000 admissions. There was one day where there were 3,500 hospital admissions in one day, but broadly speaking, it was just over 3,000. We've reached that peak again in recent days. We have more than 30,000 patients in hospital, and that's approximately 50 hospitals worth of acute patients. 2,600 of those patients are in intensive care beds, ventilated intensive care beds, and the workload is phenomenal. We're looking at something like 40% in November of our patients in ICU with COVID, and that proportion will be increasing even more through December, and it will be a much greater proportion in January as we are now, as we're waiting for the data to come through. What we effectively saw during the course of the year was a very, very effective lockdown in the spring, a very, very sharp rise in cases in March that resulted in a very busy workload through April, that stabilised in May as we got patients better and got them out of hospital. In the course of the year, there are a series of public health measures that locked us down in different parts of the UK to different degrees, and they were called tiers. There were various tiers 1 to 4. We've now added tier 5. What we saw through the autumn was, as those tiers got a little bit stricter, we saw a peak that happened in November that began to settle down, and there was a trough at the beginning around the 1st of December. We thought initially that was the second wave, that was over, and that we got over the second wave without too much fuss or bother, and that we were now okay, and that any third wave would probably be around Easter time or maybe around February time. But to our horror, we then saw numbers accelerate very, very sharply. We think this is the new variant of concern that as Stephen's described, is much more infectious. And numbers are still now rising. And the big fear was that around Christmas time, socialising in houses within the Christmas break might result in a big bounce up in numbers in January. And we think that's what we're seeing now. It's rising, it's continuing to rise. In my hospital, we've got more than 120 intensive care patients. We're hoping that will stop at around 150, but we don't know. And if it rises beyond those numbers, we're really not sure what we're going to do. We don't have a solution developed for that situation, but we know that we'll be expected to carry on taking these patients. In the first wave, we avoided a scenario where we did anything other than care for every intensive care patient who we thought would benefit. We managed to avoid anything that might look like a triage scenario or a rationing scenario. And we're trying to even avoid thinking about those terms. But what we're not sure now is whether that situation will happen in January. The lockdown that just started this week, and on Wednesday of this week for us across the whole of the UK, doesn't seem to be as strictly adhered to as the spring lockdown was. We're seeing more people in the streets despite school being closed. There are traffic jams on the way to work. The trains have more people in them than they did in the spring. And it's pretty obvious to all of us who work in intensive care when we leave work that the measures are not being adhered to as strictly by the public as they were to in the spring. And we think that you all need to get ahead of that with public health messaging explaining what the impact is. There's lots of arguments in the UK about the trade-off between economic factors, mental health factors, treatment of cancer and heart disease versus treatment of COVID. And a lot of people are trying to spin that, people who are often quite skeptical about the pandemic measures, are trying to spin that as a direct trade-off between handling the pandemic and handling other issues, such as the economy. Whereas for us, it's very, very clear that those countries that effectively handled the pandemic effectively handled the economy, cancer care, cardiac care, mental health care as well. So it's not a binary situation where we're trading off problem A versus problem B. The more effectively you handle the pandemic, the more effectively you handle all of those other problems. And really, in truth, it's about everybody's healthcare. Right now in the UK, I'm worried about everybody's healthcare, and the reason for the lockdown is to protect everybody's healthcare. Whether they are ill or not, whether they have a long-term disease, whether they have COVID, it doesn't really matter. Your situation for the general public is that your healthcare is not as robust as it would normally be because of the pandemic. And so I think you need to also be prepared for public health messaging, because it's clear to us in the UK that the voice of clinicians on the front line is having a bigger impact in some cases than the voices of political leaders, for example. The public trust the clinicians on the front line, telling them what is actually happening in their hospitals and asking them to take situations seriously. And that's also something that you need to prepare for.
Thank you, Rupert, and thank you for your testimony. It seems to me that you are referring to the fact that, again, the common theme of this pandemic so far, and there is nothing new with this variant apart from the fact that maybe it's faster, is that actually the winning is outside of the hospital with the help of everyone and citizens and containment maneuvers. Probably when you reach the stage of counting beds in hospital, it's probably too late. I'm going to ask you as well if you want to send a short message to European citizens or citizens around the world being faced with this new variant. We hope not, but I suspect that's what may come our way.
Yeah, I mean, I'd like to ask my friends across Europe to take this really, really seriously. This is a society effort, and societies across Europe can only beat this if they work together as one. As soon as we start dividing into splinter groups and debating about the best way of doing things, we will lose and you won't control the pandemic. And the impact of that could be huge.
Thank you, Rupert. We look forward to more questions to you at the end of the next presentation when you will join us for the panel conversation. So it's now my pleasure to introduce our next speaker, Dr. Charlotte Summers. Charlotte, she's also a consultant in intensive care medicine. She's also the Deputy Director of Clinical Academic Training and the Director of Academic Clinical Fellow Program at the University of Cambridge Schools of Clinical Medicine. Hi, Charlotte.
Hi, Maurizio.
How are you?
Thank you very much for asking me to speak. I thought what I would do is share some of the latest research and take the approach that slightly differs from my colleagues who've talked to you about the clinical experience and the public health response, and say, I think the wave is here rather than coming, and what can we do about it for the patients that are in front of us? First, a little bit about the new strains, then a few words about vaccines, and then the current state of play with regard to therapies as we view it in the United Kingdom. So as both Stephen and Rupert have said, the strains that we are seeing in the United Kingdom are mutated strains. They have got an increased rate of transmissibility that's probably about 40 to 70% more transmissible than the strains that we saw in wave 1. And they are inevitable. It's well known that coronaviruses do mutate, and under selection pressure, of course, they're going to. The other thing to highlight is the UK is not the only place with strains of concern. There's also a South African strain that's emerging that is more transmissible than other forms too. Whilst it's more transmissible, however, there's no evidence at the moment that the strain causes a more severe illness. It's something that was picked up quite early in the UK because we've got a massive genetic sequencing of the virus programme. So hundreds of thousands of genomes of the virus in the UK are screened regularly by a big research effort. So that's how we detected it quite early, emerging first in the southeast of the country, but now it's actually been isolated from patients in every region of the UK. But as I say, it's more transmissible, but not causing a more severe illness at the moment. But there does appear to be a change in the clinical phenotype, with us seeing younger patients who may have slightly different risk factors, or in fact fewer risk factors than the patients we saw previously. Some good news, however, is that it does look like the new strain is probably actually still detectable with the testing that we've been using, which is PCR-based testing so far. And it does look like the early data suggests that the 2 vaccines that are licensed for use in the United Kingdom, so the Pfizer and the Oxford AstraZeneca vaccine, would provide protection against this strain. Although it's too early to be definitive, that's the preliminary data. With regards to vaccines, it is absolutely important that if we are going to deal with the pandemic, that we get as many people vaccinated as fast as possible to prevent further strains emerging that are more dangerous than the one even that we're seeing now. And the message on the subject of vaccines from me, and I think everybody here, would be that none of us are safe until the entire world is vaccinated. Now, that's going to take time, but it requires a major global joined up effort, because if there's any pocket in the world where it's left for the virus to mutate, it will, and then we'll be facing this kind of issue again down the line. So a mass commitment to vaccination is vital. So in terms of therapies, I just thought I'd remind us all what we know works, and the answer to that is fairly short. It's corticosteroids. And as you all know from a JAMA meta-analysis that was published in 2020, looking at pooled data from 7 RCTs enrolling critically ill patients, 678 of which received steroids and 1,000 of which had placebo or usual care, with a primary outcome of all-cause mortality. Steroids were shown to have benefit, particularly in patients who were having invasive mechanical ventilation and who were on vasoactive medications. What doesn't work, and this is just as important as what does work, hydroxychloroquine has shown to have no benefit from 2 very large trials now. The same with other antiviral therapies. Remdesivir, whilst it looked promising initially from some early data from the United States, I think Solidarity has shown very clearly that it probably isn't of benefit. And similarly, Solidarity showed that interferon beta-1 alpha in the subcutaneous IV form was also not of benefit. What don't we know about yet? And this is very topical for today. So anti-IL-6 therapies. There have been a range of trials published to date, and thank you to Martin Landry from the recovery team for this meta-analysis of the data, showing that actually the published data so far finds no benefit on 28-day all-cause mortality from tocilizumab, the monoclonal antibody to IL-6. But I'm sure you will all know that REMAP-CAP issued a press release on the 19th of November suggesting that there was benefit from tocilizumab and serolumab, and I understand that further data will be released today. Tocilizumab is also included in recovery, and I suspect there may be data from the recovery trial in the next week or so too. Recovery are recruiting a slightly different bunch of patients, so they're not all hospitalised patients, not just critically ill ones, and it's a stratified group of patients in recovery that have got an oxygen requirement or hypoxemia and who have got persistent inflammation with a raised CRP, which is different to the patients recruited into REMAP-CAP. As of this afternoon, more than 2,800 patients had been recruited to the tocilizumab or usual care arm of recovery. What don't we know about yet? Antibody therapies, and that kind of includes all antibody therapies. Convalescent plasma was given an emergency use authorization in the United States based on registry data from 11,000 patients, which suggested that high titer convalescent plasma was of benefit compared to low titer convalescent plasma, but there was no control arm to the study. Monoclonal antibodies, of which there was much talk because the United States President Trump received them when he got sick, showed that they reduced viral levels in non-hospitalized patients and are currently being investigated in the recovery trial in the UK. And similarly, the Lilly compound, LY-CoV555, was also found to reduce viral titers in outpatients, but not again in hospitalized or critically ill people. There's a whole plethora of things currently in phase 2 and 3 trials, none of which we've got evidence of benefit for. And I include baricitinib on this list, which was recently published in the New England Journal of a trial that had baricitinib and remdesivir versus remdesivir in usual care. The effects from baricitinib were underwhelming, I think I would say. So in my view, the jury is still out about that, and there may be more trials required. So in summary, new strains of the virus are emerging and will continue to do so for some time. We need rapid vaccination of everybody across the globe, and we need clinical trials to be ongoing so that we can find treatments that work and rule out all the things that don't. And there, I think I will stop.
Thank you, Charlotte, for a very nice summary, and also would like to thank the UK as a whole for all the contribution to research. I know that you're involved with NHR and studies and so on, and I think what you've been able to do in a short period of time during the pandemic and the evidence that you brought forward is really changing practice worldwide. Is there any comment that you want to make about this for people around the world about the research, or how this is something that allowed you to learn while doing and at the same time doing robust research?
So I think one in fact, the only way out of the pandemic is actually a commitment to research. We don't have any, when we started, we had no therapies and no vaccines and no tests. And actually a global commitment to finding what works and finding tests and finding vaccines and making sure that the outputs of those research are shared with everybody across the globe is something that should be a priority for all of us.
Thank you. Thank you, Charlotte. I would like now to welcome back on stage the other panelists, and I'm also welcoming Adrian Wong. Adrian is a friend, is also a consultant in intensive care at King's, and is the chair of our editorial and publishing committee at ESIC. So I'm going to start to ask some questions, and then I will ask if Adrian is getting something from social media on top of what we have here already. Maybe Stephen, I can start with you. Why is it being so bad, do you think, in the UK compared to the first wave? And could you give us a little overview of the number of ICU beds that you had opened before COVID, and how many ICU beds you have open now, for instance?
Yes, and no problem. I think that the reason why it is so bad in the second wave rather than the first wave is probably because of the virus itself. I think that the main issue is the spread of transmission and the way that many more patients unfortunately seem to have been infected in such a rapid pace. In terms of bed numbers, we have certainly the UK has had to expand bed numbers across the board. Many units have already had to expand into new zones and expand their capacity. We have, I have to say, we are better organized this time because of the experiences that we learned from wave one, because of the organization that we put into expanding critical care units in wave one. We are slightly better organized this time, and we are able to provide more expansion areas which are not into places such as operating theatres and so on. However, that is still required in some places, and the situation is still very bad. In my own hospital, we're trying to double our critical care capacity at the moment, as are many other hospitals up and down the country, especially in the south of the country at the moment. So really, I think a more infectious strain of the virus is the reason for spread, and a huge effort. I cannot underestimate that. A monumental effort by staff is being put in to do exactly what they did again, to open beds, to expand areas. But I have to say, we are more organized, which is good. We've done it before. We know how to do it, and we've learned from the first wave. But people are exhausted. People are tired. People were hoping this wasn't going to happen again. So although there is better organization, that's combined with a feeling of fatigue and also concern for their own health as well.
Yeah, and also the fact there is being a lot of attention during the first wave about the lack of ventilators and so on, but the reality is that the biggest shortage that we have to expand ICU capacity worldwide is actually to find healthcare workers, and you don't find specialists, nurses or doctors in just a few months, and that's been a common theme for everyone that sometimes has caused a bit of confusion. I know that you, with the ICS recently, you put out a paper trying to clarify some issues about capacity and occupancy. Maybe if you want to make a short comment about that, because I've seen it and I think it's relevant to numbers reported worldwide about intensive care.
Yes, thank you, Maurizio. It's a really good question. We were finding in the media and even amongst colleagues and the public that there was a real lack of understanding about what we meant by bed capacity and bed occupancy. And at the end of the day, you're absolutely right what you've said, Maurizio. A bed, an ICU bed, is simply a piece of plastic and metal. That is all it is. An ICU bed does not make you better. An ICU bed does not heal you from COVID. What you need is you need the skilled, trained team of critical care professionals to look after you in that bed. The doctors, the nurses, the allied healthcare professionals, the pharmacists, the healthcare scientists. We need all those people to help you. We need the equipment as well. We need the ventilators, the syringe pumps, the drugs, and so on. But actually, those are the easy things to get hold of. We can make new ventilators. We can produce more drugs. We can expand areas to create more beds. But it's the staff that is the problem. And our statement from the Intensive Care Society was simply to say that when we talk about the baseline ICU bed capacity, what we mean is we mean the normal size of the unit, the normal number of beds, which has an appropriate number of critical care staff. That is a unit that runs well, that runs safely, and that gives good outcomes for patients, and has done for many years. We've got data showing that a unit run like that produces good outcomes for patients. What we're doing now is we are expanding into new areas. We call them surge areas in the UK. These are new areas. We're putting ICU beds into those areas, pumps, ventilators, equipments, but we're using the same staff. So the same staff are being spread more thinly into those new expanded areas. So we were simply drawing the point that to say an area is 100% occupied, that means the normal area is 100% occupied. But actually, if you then move into a new area, it is and half fill that new area, that means that your unit is 150% occupied, because the staff are spread much more thinly. So it's really just to indicate the fact that the most important and precious resource for any intensive care unit, the biggest difference in making patients better, will come from people, from staff.
Yeah, and I can only endorse that from a European Society of Intensive Care Medicine. I completely agree, and this is, I think, the voice that every intensive care professional say that. I think Rupert want to comment on this. I was actually coming to you with some question, but Rupert, feel free to make a comment on this.
Yeah, I should probably have mentioned it in my little spiel, but one of the differences with intensive care in the UK is we see ourselves as having fewer beds than a lot of European countries, but we have a very strict rule about one trained intensive care nurse per intensive care bed. And if I understand correctly from friends around Europe, that's a much stricter rule than I see in other European countries. We've diluted, is the phrase, that rule from one nurse per trained nurse to one trained nurse for 3 ICU beds. And it's looking like even one nurse for 3 ICU beds is going to be difficult to maintain. And that staffing is backfilled, at least in my hospital, by not untrained nurses, but not care, also with medical students. Over New Year's, even consultant colleagues, consultant surgeons, consultant hematologists were turning up to work alongside nurses to do nursing care because we were so desperate for nursing staff. That's how the situation has reached for us. And of course, our nursing colleagues, we know they are the main vehicle of everything. Every decision I make as a consultant goes through my ICU nursing colleague. And then at the bed space is absolutely vital. And when you've got one ICU nurse with 3 patients, as I had at the weekend, 2 of them on hemofiltration, all 3 ventilated, 1 fails decannulation of tracheostomy. She's got 2 nurses from coronary care working with her. She cannot turn her back for a moment. If the filter alarms, if the ventilator alarms, she cannot leave the bed spaces. To do that for 12 hours solid is intensely stressful for our ICU nursing colleagues. If there is one single group of people that this pandemic has hit hardest, it's our ICU nurses. So just to sort of emphasize the importance and complexity of that.
Yeah, I completely agree. And actually, I think these are the stories that we receive from everywhere. In Italy, I can say the same is in order to keep the number of healthcare workers at the bed space, we had to redeploy healthcare workers from other clinical areas. I think that's also one of the messages that is important to pass to the public, that when we have to do that, we have to shut other clinical services. And this also has an impact on healthcare. And these people that do not work regularly in intensive care, they try their best, but we have to try to train them, and you cannot train them into specialists just in a few days. We've done some courses with the European Society of Intensive Care Medicine and the European Commission, like C19 Space. You participated, you've done similar things, but that's not the same thing, the training specialist, and it's a very stressful way. way of working. I agree. Charlotte, can you help me to understand the demographics of this new variant? We read reports, and this was also commented by Stephen before, that it seems to affect more young people. Is this only in the infection numbers, or is this also translated into hospitalizations of younger people compared to the first and second wave?
So, compared to the first wave, again, we're seeing in the second and third waves, actually hospitalizations in younger people, and by younger, I mean the kind of 19 to 30 sort of age group, are unusual. It's very unusual for healthy people of those ages to get admitted to hospital. But the transmission rate of the virus is much higher in the 18 to sort of 30 to 40-year-old population. So it means they're more likely to be exposed. And if they're exposed, actually, we've seen clear evidence of transmission from that group to the older population. And so that's what's led to increased numbers of admissions to hospital. In terms of the UK and ICU surveillance, we're incredibly lucky that we're the home of ICNARC, and ICNARC have done an amazing job during the pandemic with looking at the demographics of the patients who are admitted to intensive care. As it stands at the moment, for everyone admitted from the 1st of September onwards, the median age is no different to those admitted between the beginning of 2020 and the 1st of August or 1st of September. The median age was 60 in what was described as wave 1, and it's 62 currently from the 1st of September onwards. But we know that there are increased amounts of transmission in younger people. It's just not coming into hospitalizations in the same way, but they spread to the rest of us. And the big worry is that obviously social mixing over Christmas and the New Year period, people go to see their grandparents and their wider family, has led to an increase in the number of hospitalizations, which will lead to increased ICU admissions and increased deaths. For the first time yesterday, more than 1,000 people died in a single day in England from coronavirus infection.
Yeah, and this median age, there may be some lay people following us today. Just to explain, we have basically 50% of people in our intensive care unit across Europe, and this median age seems to be relatively stable between 60 and 63. It means that half of our patients are below 60 years of age, which by my standard is still considered young. We don't see kids, that's a good thing, but we still have very young people in our intensive care units. I'm looking at Adrian. Adrian, did you get any questions from social media?
Yes, I do actually. So it's a recurring theme, and it's a question primarily for Stephen and Rupert because you brought it up. And Charlotte, we will value your opinion. All of you mentioned that staffing is very important, and we're trying to spread them out more to look after more patients, i.e. maximizing the quantity of patients that we are looking after. It's a provocative one, but at some stage, the quality of care that you can deliver, want to deliver, becomes a compromise. And putting it out there, there might come a point where actually you might be causing harm by not focusing your attention to a smaller number of patients. Your thoughts?
Well, Adrian, thank you for the question. I think that unfortunately that is a very, very real risk. And Rupert has described very eloquently the scenario of the one trained critical care nurse having to look after 3 patients. Yes, the other 2 patients do have a nurse with them, but not a trained critical care nurse, and therefore the cognitive load that is applied on that critical care nurse, not only to care for her own patient or his own patient, to care for the other 2 patients as well, and supervise the other 2 nurses, bedside carers who are delivering care, is extreme. And that will lead to stress, that can lead to mistakes, and that can lead to worse outcomes. So I think all of us in the Intensive Care Society have a grave concern that as the pandemic worsens, as the quality of care that we deliver is diluted and the nursing ratios are diluted, that there could be risks to patients. We know at the worst part in the first wave, it was 1 critical care nurse to 6 patients. that resulted in great deals of stress to staff and also harm to patients. We did see that whenever ratios get to that stage, basic care is more difficult to deliver. Turning of patients, skin care, nutrition, and hygiene. And those are the basic requirements that any patient will require in an intensive care unit. So it's not just the big outcomes as well, it is basic human care that is at stake here as well.
Rupert, do you want to comment?
I would echo all of that, Adrian, that Stephen has said, but I think the key phrase for me there is the term cognitive load. And that really resonates with us. It's just the sheer inability to relax for a moment if you're at the bedside because there's so much going on. We're having conversations about how, as consultants, we can deliver a much simpler, more streamlined package of management for the nursing staff, so there's fewer tasks for them, trying to avoid doing those things that we might feel intellectually interesting or academically interesting, but actually we're not that confident that they're going to help the patient. And that's something that we're used to doing in intensive care because we're very thoughtful about it, but we're having to put that to one side, which means we're having to change the way we work, which is uncomfortable for us. But I think the root answer to your question is it's not a question for intensive care doctors to answer it, or nurses. It's a question for society to answer. What does society want us to do? We're their servants. What would they like us to do in this situation where we cannot be the best of ourselves? Now, one of my fantastic ICU colleagues tried to open up this conversation in a group email within my team. And to our horror, that email was leaked by an ex-colleague who happened to still be in the email group. And it's found its way into mainstream media. And the initiation of a conversation about how do you cope when you cannot deliver the quality of care that we are drilled to deliver day in, day out. How do we relax that? How do we stand that down and handle that emotional change in our minds as intensive care staff? Well, it seems like society is prepared to squash that conversation and stop us from even having it. So the mental health burden of that sits on us as intensive care doctors and intensive care nurses. And I'm not sure that's okay. I'm not sure I'm happy with that as a doctor. And what I would encourage people in other countries in Europe to do is to get ahead of that discussion. Whilst it's not happening, ask your society, if this thing happens, if this bad thing happens, we hope it won't, we're going to do everything we can to make sure it doesn't. But if it did, what would we do? How would you want us to deal with that? Would you want us to make decisions based on age? Would you want us to make decisions based on comorbidity? Or would you just want us to admit everybody but not be as good? Because if society approves that approach, then I think as a doctor, I feel more confident that I'm at least doing what society's asked of me. But right now, intensive care as a profession, be that nursing, physiotherapy, doctors, whatever it might be, we're owning that responsibility. And I don't think, if it does get really bad, I don't think we'll be able to cope with the stress of it, to be honest.
Charlotte, do you want to comment?
I think the thing that I would highlight is that the dilution of nursing staff ratios particularly is not something that's just happening for a few days or even a couple of weeks. This is something that has intermittently been going on for months, on and off in a lot of units since the beginning of March. So it's not that the kind of spirit that everybody had about how we're just going to get through a really bad few weeks at the beginning of wave 1 in early 2020 is there. People are starting to have to do this again from a baseline that is very different to wave 1. They've had 10 months worth of working flat out and of having that cognitive load that Rupert talked about. And then we are having what looks like it's going to be a worse wave, and then asking them to own, as Rupert's rightly described, the moral burden of having to decide how we cope in the situation where we may end up having less resource than we would like to be able to tend to the number of patients we've got. That is not, in my personal view, an appropriate thing to ask of anybody. Sickness rates are already increasing in nursing staff. and medical staff, and they're going to increase further if we give them that moral burden. So I would plead all of you to have very public conversations about what's coming in the cold light of day to support your teams, because it's what needs to happen.
Can I stay with you, Charlotte, because the support is within the intensive care, but when a situation is so overwhelming, we start to see also level 2 patients or patients that sometimes we were bringing to our intensive care units like CPAP and non-invasive ventilation, populating other wards like respiratory ward. That's certainly my experience during the first wave. In Italy, a bit less during the second wave. But I was wondering, is this something that you're also seeing there? And how do you support all the colleagues that are not used to see so many patients, if they have these patients in respiratory ward, in medical wards with CPAP and so on?
So we are fortunate in many respects in the United Kingdom that respiratory medicine has for a very long time had a brilliant ownership of acute care of non-invasive support. So almost every hospital in the United Kingdom can provide non-invasive ventilation under the care of respiratory physicians because it's a core competency for them. However, they're not used to supporting large quantities of people with hypoxic type 1 respiratory failure who are for escalation. So it's a very different population to they might normally see, and in much larger numbers. So key to that has been close working between critical care and respiratory medicine. But we're definitely starting to see, as the pressure comes on the system, people who are having CPAP for probably longer than is appropriate, which is leading to increased amounts of pneumothoraces and possibly some later ventilation of people than is appropriate. And I think it's important for us all to be clear that there is no good evidence to suggest that either CPAP or invasive mechanical ventilation is the appropriate strategy. We are doing this in an evidence-free zone. I realise that saying that is going to be very unpopular with pretty much everybody because there's two very firm camps about it. But we do not know. And it's something that, again, I would say we need to randomise to understand. But anybody who's certain that CPAP or invasive mechanical ventilation is absolutely the way to go is, of course, wrong because we don't know. There is uncertainty.
But I think a point that you made, which I also think is valid in many other countries, is that in these respiratory wards, often the nursing ratios and consultant ratio are as good as we afford in our intensive care units. So when they stretch, the stretch sometimes is even harder for them. Did you have to implement more outreach teams in this sense from your intensive care unit to provide this support? I don't know, Stephen or Rupert, if you want to comment on this.
Yes, I think the issue of non-intensive care workers is something that's really important, Maurizio, and I think it's something that's worth emphasising. So outreach is one example that you've mentioned. Yes, undoubtedly, outreach workers have had to double their efforts, triple their efforts to visit and assess and treat patients on the wards. We are seeing huge numbers of patients who are indeed critically ill, patients who would normally be admitted to critical care units, being cared for in non-critical care wards, in normal wards, acute general wards. Those patients are extremely unwell, and the ward medical teams who are looking after them, respiratory medicine, infectious diseases, general medicine, are working extremely hard to look after them. As well as that, right at the front door, we need to remember our emergency medicine colleagues and our paramedics and ambulance teams as well, everybody working extraordinarily hard. So I think this is a disease which is affecting not only thousands of patients, but many staff across many different specialties and areas of work. I think that intensive care medicine does get a lot of attention. That is appropriate. We do deal with some of the sickest patients, but sometimes we do not pay enough attention to our other colleagues who are stressed and stretched just as much.
Yeah, I agree. Rupert, you are probably seeing as many ICU patients as anyone else in the world with this wave, and considering where your hospital is in London now. I did find very difficult, especially during the first wave, and now we found some ways sometimes to make it different, but it's not easy. not to have families at the bedside. That human aspect of care got a bit neglected just because we were so busy with life-saving procedures and with the fact that we were very worried about infecting relatives coming to our intensive care unit, even if in a way, probably intensive care unit seems to be safer than other places. Can I ask you, how is it being in London, where you work? How do you deal with this aspect of families not being there at the bedside as much as we were used to a year ago?
Yeah, I think this is a really important point, Richard, because it's one of the single most stressful things, both for families, for patients, but also for staff. One of the most traumatic things I've done so far was to stand by a patient's bed and phone her husband and say she was dying. And I found that really just no fun at all. That's just not how we normally do it. We would normally take a very protracted process over several days, meeting family face to face, standing around the bedside together to work those conversations through. So that particularly, I think, is very, very harsh. What we've done in the second wave is to be more flexible, more thoughtful in family visiting. We do try and say, look, more than 2 people really isn't going to work for us. But we also try and bear in mind that there's always exceptions to every single rule. So we try to listen to that. The problem is, of course, the amount of time it takes to manage that. Family members need to be escorted from the door of the hospital into the hospital, shown how to don, how to doff, how to behave so they're safe at the bedside. That all takes a lot of resources. So we're not having routine visiting at all. We are having end-of-life visits. That's a standard thing for us, and I think that that's a big relief on all of us that we're having those. Other visits are really the exception, and really on clear, compassionate grounds where there's a strong argument. Often what you then see, I had a patient this weekend where we said, okay, family member can visit. They said, well, they wanted the patient's husband to visit, but the patient's husband was 80 years old. And we then had to turn around and we really don't think that's a good idea. That's too much of a risk, and we think that. But then you have to get into a big conversation with the family about that. And the rules become advice and then go back to being rules, and it's quite hard to administer, and that all takes time. Zoom calls or whatever a platform that you might use, we've got a team of medical students going around with a tablet computer so families can see their loved ones, even if they're on a ventilator and can't talk. Just seeing them and seeing the nurse looking after them has had a huge impact on their confidence in us and their being. And of course, if that whole communication process is handled well, that engenders confidence for families at home. The other thing we've done for low-risk patients who don't really have much going on any given day, we've had a brag rating of patients who are stable. The doctors enter a brief update for the family onto the electronic patient record, and our medical students then read that off and then phone the family to tell them. And then that allows us to focus on the complex, serious problems with patients who are unstable, and allowing other people to hand over basic, simple information. You know, they were well today, they sat out of bed today, they're chatting with the nurses. Nothing too specialist, but those kinds of things can really help the family, help staff with their mental health, and also offload on tasks.
Yeah, I agree. Adrian, I think we're receiving some clinical questions that from social media. I don't know if you want to get one or two of the burning ones.
There have been so many questions. Moving on to more clinical topic, and on the topic of NIV, CPAP, that's already mentioned by some of you. Comparing your experience from the first time round to this time round, I know it's still early days of this time round. Have you noticed a change in our readiness, utility of CPAP, high flow nasal oxygen, and hence its effect on intubation timings and so on?
Adrian, I can make a comment on that. I'm always keen to make a comment on NIV, CPAP, and invasive ventilation, as Charlotte knows. I think I have seen a difference actually, and I can't explain it, but it is concerning. I think that we certainly know that there is a much greater use of CPAP and NIV in the second wave. Our experience in the first wave was that the patients either didn't get CPAP NIV at all, or maybe got it for a very short length of time. We were concerned about viral spread and the aerosol generating procedures, which included CPAP and NIV. Now that we have got better PPE, more access to PPE, those therapies are much more readily used, but as Charlotte says, used probably without a firm evidence base. What I have seen personally working in an ECMO centre is that the patients that are referred to us for ECMO, certainly at the beginning of the second wave, seemed to be referred to us with more barotrauma. We were seeing cases of subcutaneous emphysema, sometimes of pneumomediastinum, sometimes with overt pneumothorax. That is not something I saw a great deal of in the first wave, and we suspect that could be from prolonged durations on CPAP NIV in increasingly consolidated and increasingly non-compliant lungs. So I would caution clinically against prolonged CPAP NIV in these patients. That certainly can lead to complications, which we're certainly seeing through our ECMO referrals.
Charlotte, maybe?
It's really clear when you look at the ICNOC data set that the use of invasive mechanical ventilation decreased from the beginning of 2020 towards the end of the year. Whether that was responsible to improvement in mortalities is often advocated, I think, is less clear. And I think, as I said earlier, we do not know which is the right strategy. And we are seeing increased complications, as Stephen has highlighted, and patients that are taking quite late and abrupt deteriorations. So I think that the jury is very much still out. The other thing that I would say is some of the observational cohort studies that have been published, even in patients that were for escalation from CPAP to invasive mechanical ventilation, actually 2/3 of those patients failed and ended up getting intubated. They just got intubated at a later point and potentially had increased mortality in some of those data sets. So whilst you might save or improve 1/3 of them from having invasive mechanical ventilation, you may actually worsen the outcome of the other 2/3. And whether that's a price what's worth paying is something that we need to consider.
Yeah, just because I'm conscious of time, I'm going to ask Adrian to ask the next question, and rather than go around 3 times, maybe Rupert can start with the answer.
The question, Rupert, is now a very, very specific therapy that Charlotte didn't mention. It's been mentioned by a couple of colleagues on our social media, which is ivermectin. What do you think? Are you using it? Is that a potential? So on, like I said, it's one that Charlotte didn't mention.
Yeah, I mean, there are scores of therapies that are highlighted often on social media that really have no evidence base at all, but people are talking up that they do. And often they're talking about laboratory studies, or they're talking about observational studies, or they're talking about very, very, very small randomized trials. And they'll go, there you go, that's the evidence, just do it. Well, the lesson of my career has been that the randomized trial in intensive care medicine has led to us doing fewer and fewer clever things that felt intellectually stimulating for doctors but didn't alter patient outcomes. And the consequence of that is that patient outcomes have improved, mortality has fallen, because we are better at doing the basic things well. So if ivermectin works in a large randomized trial like the recovery trial or like the solidarity trial, I will be the first to be prescribing it. If it's being tested in such a trial, I would be happy to randomize my patients to it. But until such a trial's been done, I don't think we have the evidence base to use it. I think it would be very risky if we started a culture of just using things without clinical trials, because sadly, most of these things don't work. And it's okay for them not to work. It's a good thing to know that. It simplifies our care, it debulks our care, it makes the job of the nursing staff easy. And then when we do hit on a dexamethasone, wow, that's a lifesaver, and that's really good.
Yeah,
Charlotte will say something much more intelligent there.
And we are treating a population that, luckily for us, and thanks to what we do, we're still a majority of people that survive rather than dying. So to associate survival with random therapies is not something we can assume without trials. I think, Charlotte, I can see you want to comment definitely on this.
I was going to just make a very brief comment as one of the, so there's a group of 5 or 6 of us that are the UK COVID Therapeutic Advisory Panel that advise the Chief Medical Officer of what therapies should be deployed in the national clinical trials. And just to be clear, we have absolutely looked at ivermectin, and you will note that it has not been deployed in a national clinical trial in the United Kingdom. And I would say that that should tell you something about the view that we took of the evidence base for that therapy at the current time.
Yeah, very importantly. There is a question that we didn't ask. There are reports, especially when we are so stretched with our intensive care units around the world, but I don't know if it is because of the quality or if it's because of something that happens. Are you seeing any increase in severe infections or multi-drug resistant infections in your units during this wave or not? It's a simple question, but there are several reports from around the world. So I'm interested to see what you're seeing in the UK. Stephen, maybe?
I have to say we are seeing a lot of secondary bacterial infections in our patients. I look after a unit with predominantly ECMO patients at the moment. Those patients are incredibly sick. Many of them will develop secondary bacterial infections, often complex to treat. But I must say I'm not seeing particular multi-drug resistant infections. To me, so far, it seems to be the normal bacterial infections that we would normally see in this population.
Rupert?
I think it's important to highlight Stephen's case mix and my case mix is different. We've got a lot more of the patients who come through the door of the emergency department, and Stephen's got a lot more of our very most challenging patients. I'm seeing a lot fewer bacterial infections than I might normally see, and a lot fewer drug-resistant infections. Even MRSA seems anecdotally to be not that common. And in fact, we're rowing back on even the use of antibacterial first-line medication in our patients.
Okay, very good. Adrian, I think we have time for one last question from social media before we close, maybe to Charlotte.
Okay, one of the other questions that's been posed, and is an observation stroke, therefore a comment, is the use of renal replacement therapy. Have you noticed a change in terms of how much is used first wave versus now?
So about 30% of patients required renal replacement therapy at some point during their ICU stay in wave 1, and that has declined over time. The reasons for that are not clear and probably complicated, is the brief answer.
Okay, very good. Thank you, Charlotte. Sorry, it's 5:05 Central European Time, 4:05 in the UK. We have to come to a close. I know there are many questions. I suggest if there are more questions, Adrian, maybe we will try to post them in our blog, and maybe we can ask the panels to comment in the next few days. Personally, I really would like to thank you all for your time, for sharing all your experience with you. I guess the reassuring thing for me is that many of the clinical things and organizational things that we've learned last year, they still hold even for this variant. However, you are telling us a clear message is that this variant is very fast, and it's something that we have to win only with the help of the society and the community, and probably we have to get ready. Stephen, I would just leave one very last short sentence to you as president of the Intensive Care Society as a symbol of thanking you all in this panel for sharing your experience with us today.
Thank you very much indeed, Maurizio. My final sentence would simply be to thank you, our friends and colleagues in the European Society of Intensive Care Medicine and across Europe. We are without doubt stronger when we work together, and I have no doubt that through the endeavour of everybody that we will come through this second wave and we will learn more about it and we will be able to treat patients more safely at the end of it. But be ready when it comes.
Thank you all, and help us. Bye-bye.
Thank you.
Thank you all.